Neurodevelopmental and Neurogenetics Clinic. He's part of the Developmental Neurogenetics Program, which specializes in the diagnosis and management of genetic disorders associated with neurodevelopmental disabilities. So he sees patients in the multidisciplinary Phelan-McDermid Syndrome Clinic and the P10 Clinic. His goals are optimizing long-term and neurodevelopmental outcomes and coordinating specialty care across disciplines. He also does research involving the different genetic causes of neurodevelopmental presentations, such as autism, intellectual disability, cerebral palsy, and developmental regression, and using the multimodal approach of gene discovery, cognitive behavioral phenotyping, and biomarker identification. So without further ado, Dr. Sid, thank you so much for joining us.
Great. Thank you so much for that introduction. For those of you who don't know me, my name is Srivastava. I'm one of the child neurologists at Boston Children's Hospital. I'm focused on neurogenetics and neurodevelopmental disorders. And today I'm really excited to talk about our randomized control trial of everolimus for neurocognitive symptoms in P10 syndrome. We just published the results of this study, and I'm really excited to talk about this trial. Just before we get started, just some basic background. This, of course, is not new to the audience, but just a quick general overview slide. As we all know, P10 syndrome is associated with germline pathogenic variants in the P10 gene that result in a wide spectrum of systemic challenges as well as neurodevelopmental challenges. Systemic challenges include, of course, increased cancer risk, GI issues, vascular anomalies, skin findings, among a sea of other features. There is, of course, a very wide spectrum of neurodevelopmental challenges that we see in P10 syndrome. This includes macrocephaly or enlarged head size, intellectual disability, autism spectrum disorder, and a wide range of other neurodevelopmental challenges. Specifically, P10 hematoma tumor syndrome is associated with challenges in frontal lobe systems. And what I mean by that is impairments in terms of attention, in terms of impulsivity, reaction time, processing speed, and motor coordination. Taken together, all of these features represent a significant source of impairment for patients as well as family members and care providers. The pathophysiology of P10 syndrome is, of course, very complex, but one key component is dysregulated mTOR signaling. So let me kind of break this down a little bit. So P10 acts like a brake on the mTOR pathway. The mTOR pathway plays a role in terms of things like cell growth or regulating cell growth. The mTOR pathway also plays a really important role in terms of the development and maturation of the synapse, which is this fundamental unit of learning, memory that occurs in the widespread in the brain. So in P10 syndrome, the P10 brake is not as effective on the mTOR pathway. So mTOR, as a result, becomes relatively overactive. When mTOR becomes relatively overactive, there's increased cell growth, which underlies the increased cancer risk we see in the syndrome. It also can underlie the increased propensity for different tissue growths. And because mTOR also plays a really important role in the development of the synapse, that's why in P10 syndrome, this imbalance of mTOR signaling contributes to this wide spectrum of neurodevelopmental challenges that we see within this disorder. Treatment of these neurodevelopmental symptoms in P10 syndrome is really largely supportive, but there's some increasing data from animal models, small case reports, and small interventional trials that have suggested that mTOR blockers or mTOR inhibitors may be helpful. So more specifically, there's some animal model data that showed of P10 syndrome that showed that these animals developed autistic-like features that were improved with the addition of a mTOR blocker called rapamycin. And in humans, there are some small case reports of the mTOR blocker sirolimus improving things like overgrowth and painful vascular anomalies seen with these patients. There's a small interventional trial that was published that suggested that the mTOR blocker sirolimus improves symptoms in adults with P10 syndrome, specifically baseline symptoms, skin lesions, GI polyps, and cerebellar function. However, there hasn't been, as of yet, or before this trial, a randomized control trial that has looked at the use of mTOR blockers targeting cognition and behavior in humans with P10 hematoma tumor syndrome. So to address this shortcoming, we did exactly that. So we just completed this clinical trial, which we started in 2017. So the question is, why did we select everolimus? So this drug is currently FDA approved for use in another genetic disorder called tuberous sclerosis complex, which is also related in the sense that there is increased or overactive mTOR signaling in that genetic disorder as well. But the efficacy and safety of everolimus for P10 syndrome has not really been adequately established as of yet. And why assess neurocognition? Well, I think as a neurologist, I'm biased, but I think this is a really important domain that we should pay attention to within the context of P10 syndrome. And for the purpose of this trial, we chose a wide range of different neurocognitive and neurobehavioral endpoints, just because it encompasses P10 syndrome has such a wide complexity in terms of that neurodevelopmental profile. We also studied biological or biophysiological markers, including EEG outcome measures, in addition to these neurocognitive and neurodevelopmental outcome measures. So let's talk about the research design of this trial. This was a phase 1 and 2 double-blinded placebo-controlled trial with everolimus. It was a multi-center trial. In terms of the trial aims, our primary objective was to evaluate the safety of everolimus for use in individuals with P10 syndrome. Our secondary objective was to evaluate the efficacy of everolimus targeting cognition and behavior in humans with P10 syndrome. As I alluded to earlier, we chose a very wide variety of different neurobehavioral measures. So we chose a neurobehavioral neurocognitive composite score based on a working memory score, based on a processing speed measure, based on fine motor measure. We looked at overall clinical improvement. We looked at measures of autism, social symptoms. We looked at measures of other behavioral challenges. We also looked at measures of adaptive skills. And then we also looked at physiological biomarkers, including eye tracking tasks, including auditory potentials, and including resting state EEG data. This trial occurred at 3 different sites, including Stanford University, whose PI is Dr. Antonia Hardin, Cleveland Clinic, whose PI is Dr. Rabi Hanna, and Boston Children's Hospital, whose PI or principal investigator is Mustafa Sahin. In terms of the participant flow of this trial, individuals who participated were randomized to either receiving everolimus for 6 months or placebo for 6 months. Those who were randomized to placebo had the option to do a 6-month open label phase where they could receive everolimus. There is a long list of inclusion criteria, but I've highlighted kind of the main pertinent ones. Individuals aged 5 to 45 years of age with confirmed P10 mutation could participate. They had to speak English, and they had to be able to participate in one of these 3 kind of core neurocognitive measures, including the Conners Continuous Performance Test, mean reaction time, which assesses processing speed, Stanford-Binet working memory test, which assesses working memory, and the Purdue pegboard test, which assesses fine motor coordination skills. There was a lot of course, exclusion criteria. I won't go into details of these, but I'll leave this in the slide. And skip over this for the sake of time. Everolimus can be associated with a wide range of clinical side effects as well as laboratory side effects. Many of the clinical side effects can be mild, moderate. They can be transient in nature, which means that they can get better over time. Common side effects of everolimus include GI side effects, including stomatitis, which is basically kind of like an inflamed mouth, sores inside the mouth. Everolimus can also be associated with laboratory abnormalities, including abnormalities in blood counts, issues in terms of cholesterol levels. It can be associated with kidney dysfunction and so forth. As part of the clinical trial, we monitor for all of these different side effects. So what did our study trials show? And so let's talk about the results, starting with participant characteristics. This is a flow chart that talks about our enrollment. We assessed 55 individuals for eligibility. Out of these 55 individuals, we excluded 9 individuals. So we randomized 46 individuals. These 46 individuals were randomized into 2 groups, the everolimus group and the placebo group. There were 24 individuals in the everolimus group and 22 individuals in the placebo group. Out of these 46 participants total, 89%, or 41 out of 46, completed the study. This slide talks about participant drop-off. The first thing I want to highlight is the dropout rates in the everolimus group and the dropout rates in the placebo group. In the everolimus group, 3 out of 24 participants, or 12%, dropped out versus 2 out of 22 participants in the placebo group, or 9%. Basically comparable rates of dropout between those 2 groups. Next, I wanted to talk about dropout for the everolimus group in particular. We looked at dropout due to one of 3 categories: dropout due to participant or parent request, dropout due to investigator request, or dropout due to other request. In the everolimus category, there was 2 participants who dropped out due to participant/parent request. The first participant dropped out due to concerns about abnormal blood cell counts, so neutropenia and thrombocytopenia. The second participant that dropped out due to participant or parent request was an individual who had repeated instances of stomatitis, which is that kind of mouth sores, inflamed mouth. In the dropout due to other request category, there was an investigator-initiated dropout request because of a participant for whom there were safety concerns due to appropriate medication compliance. So in this slide, I wanted to talk about characteristics of these participants, baseline demographic characteristics and clinical features. The big takeaway of this slide is that in terms of age, sex, race, and clinical features such as autism diagnosis or IQ, there's no statistically significant difference in characteristics of any of these features when comparing the everolimus group versus the placebo group. So now let's talk about the results of this study, starting with safety. This is a slide that talks about serious adverse events that have occurred in the everolimus group and also the placebo group. So there are no serious adverse events in the placebo group, not surprisingly, but there were 3 serious adverse events noted in the everolimus group, and I'll go through these 3 instances in more detail. The first one was potential suicidality reported by a school member, but again, this was before the onset of any study drug. So this patient had not actually even received any medication yet. So this was deemed to be unrelated to the trial. The second serious adverse event that was reported, and again, we have to report everything, whether we think it's related to the medication or not. So this was an emergency room visit for significant abdominal pain. Again, also this was before the patient received study drug, so unrelated to the medication. The third serious adverse event we reported was the hospitalization required for IV fluids in the setting of a possible infection called enterovirus infection that causes a pretty bad GI bug. In this case, we weren't sure if this was related to the study drug or not, so we rated this as being possibly related to the study drug, but not definitely related to the study drug. What about other adverse events, or what about other side effects that were reported? This slide breaks down the other side effects that were reported in terms of big categories, and it looks at the prevalence or percentage of adverse events in the everolimus group and also in the placebo group. The big takeaway, which I've highlighted in green, the only category that showed a statistically significant difference in percentage of adverse events in the everolimus group versus the placebo group was GI or gastrointestinal category. And again, this includes the side effect I mentioned earlier of stomatitis, that kind of inflamed sore mouth sores and things like that. The prevalence of GI side effects was much higher in the everolimus group versus the placebo group. In terms of big takeaways about safety of everolimus for use in P10 syndrome, our experience with P10 is similar to our experience with the genetic disorder I mentioned earlier, tuberous sclerosis complex, for which everolimus is used and FDA indicated. The majority of adverse events related to everolimus are mild and transient in nature. The main category of side effects that we saw was GI related, particularly stomatitis. So now let's talk about efficacy. The slide here shows whether everolimus improved our primary neurobehavioral outcome measure. So again, this was a neurocognitive composite score that was based on a working memory measure, based on a processing speed measure, and based on a fine motor measure, or based on a motor skill measure. The big takeaway here is that everolimus did not show an improvement in this primary neurobehavioral or neurocognitive composite score. So from time point baseline to 6 months, there's not a statistically significant difference or impact on this primary outcome measure, this neurocognitive composite score, which is disappointing. However, what is promising is that when we looked at these other outcome measures, these other neurobehavioral outcome measures, we started to see some really interesting signal in the direction of improvement using everolimus compared to placebo. So the first slide I'm showing, or the slide I'm showing here, talks about some of these other secondary cognitive outcome measures. And what I've highlighted in green shows the Stanford Binet 5 nonverbal IQ score. And notice the bolded effect size. So while, in other words, I guess the takeaway here is that there's a trend in the direction of improvement with the nonverbal IQ in the everolimus group compared to the placebo group. Again, it's not statistically significant, but the effect size is, I think, meaningful. This slide shows some of the social, behavioral, and adaptive secondary outcome measures. So the first green box shows the social responsiveness scale, a social communication measure, total score, and there was improvement in this social communication measure in the everolimus group compared to the placebo group. And this did show a statistically significant difference in the everolimus group compared to the placebo group. The second green box in the middle shows the child behavioral checklist score, and as well as the short sensory profile score. And both of these, while they were not statistically significant, they did show a meaningful, I think, effect size of 0.23 and 0.31 respectively. So again, there's a positive signal in the direction of improvement in these two areas in the everolimus group compared to placebo. The Vineland-3 is an adaptive behavior measure, so measuring things like self-help skills. Again, a positive, a good effect size that suggested a trend towards improvement in the everolimus group compared to the placebo group. This slide shows some of the motor secondary outcome measures. One of these motor outcome measures, the Purdue Pegboard test, which is a fine motor coordination skill. One of the metrics on the Purdue Pegboard test showed a statistically significant difference, meaning, again, improvement in the everolimus group compared to the placebo group from time point baseline to 6 months. Here is just a visual depiction of two of these measures I've showed that did show statistically significant differences from baseline to 6 months. So on the left is the Purdue Pegboard test, left-hand standard score. This is a fine motor coordination, fine motor measure. And on the right is the SRS, which is the social responsiveness scale, which is a social communication measure. And these were two of the measures that showed statistically significant differences, meaning improvement in the everolimus group compared to the placebo group. The other really interesting thing is in addition to these neurobehavioral, neurocognitive measures, we looked at biophysiological measures, including EEG. So this graph here shows resting state, alpha power, and beta power. And again, we don't need to get bogged down in the details of what these represent. But what I wanted to say here is that there was a significant change in both of these metrics in the everolimus group versus the placebo group. And the direction of change is something that, we could hypothesize what it means. One thought is these specific areas could be related to changes in a particular rhythm called the mu rhythm, which can be associated with just improvement in terms of motor and social domain. So again, it's, I think it's very interesting data that there is a positive physiological impact with everolimus. So to wrap up this talk, just the big main conclusions from this trial, and I'll just read out these main points here. So the first point is that everolimus is well tolerated in the P10 population in this P10 study. Adverse events were similar to what's been reported before in previous clinical trials, including for the genetic disorder I mentioned, tuberous sclerosis complex, and also in clinical practice. Although the primary efficacy endpoint didn't show improvement, there were several of these secondary efficacy endpoints that did move in the direction of improvement, which I think is really exciting and to me, and I think really promising. And then even especially the fact that there was not just improvement in these functional measures, but also in these biological measures and this EEG measure also that suggests that there may be target engagement of everolimus in the brain in the doses we use in the trial. With that said, just to acknowledge first and foremost the families for participation. I learned so much from the families. We are so indebted to the families out there. Thank the P10 Research, P10 Foundation, thanks for Autism, the site PIs who I mentioned earlier, the analysis team members, and funding for this study, which is listed over here. Thank you so much.
Thank you for your time. I might have a few questions.
Sure.
I have a daughter that's been on sirolimus for about 3 years, more or less. And I have several questions between, first of all, it's very positive to see that, like you said, I think in the secondary testing that it did improve cognition. Is there any relation that you find from a P10 diagnosis coupling with other, I'll say, vague brain diagnoses such as a schizencephaly or neuronal migration disorder? I'm basically, and this might be more of an advocate question for later, I'm trying to find strong enough language so that when I go back to the child study team, Right now, I guess P10 is under other health, but I'm looking for some stronger language so that she can be protected when she's at school. And also, if there is a difference, or if you've seen any evidence of those diagnoses, as well as silent seizures.
Sure. Yeah, that's a great question. One of the questions is that when you look at this study population, this clinical trial, when you subdivide by certain clinical diagnoses, so autism or seizures or whatnot, we weren't powered, the study wasn't powered enough to make those kind of divisions, but I think that's would be certainly interesting nonetheless to see what about those kids with P10 and autism versus, or those kids with P10 and epilepsy, or those kids with actually I'd say kids and adults because we included individuals 5 to 45. I think that would be really interesting, and that's one of the next goals for this analysis, to look at those subgroups. The second part, or another answer to your question, in terms of, so we've published on individuals on a certain type of brain malformation called polymicrogyria that can be seen in the setting of P10 syndrome, and there's some data to support that maybe those who have P10 syndrome who have polymicrogyria in addition to P10 syndrome may be perhaps more impacted developmentally than those without polymicrogyria. Again, it's preliminary data, or not preliminary, but limited data, I should say. I'm happy to talk to you offline about strategies to strengthen the recommendations you can make towards the school. I think that's a really great point, but I think we can talk offline separately about that.
I think for people online, the chat is muted, so if you raise your hand, I can also call on you and you can speak up.
Yes, thank you. My question is, what's next? Do you foresee larger trials? Do you foresee this becoming a actual treatment? Or is this saying, we need to do more research into similar types of drugs that maybe have less GI problems and more benefits?
That's a great question. So what next? What do you do with this? So there's the takeaway from this trial is that there's a possible, certainly a very interesting and possible signal with mTOR blockade or mTOR inhibition in this population. This was a small trial in the sense that there are only 46 participants who were randomized. So that's, I think, relatively small, so to speak. So I think you need larger numbers. You need to think about what about, we use everolimus, what about sirolimus, which is also an mTOR blocker, but a little bit different chemically. What about larger numbers to make those more, what are the specific subtypes who may respond better than those who may, in other words, let us think more carefully about whether there are certain subpopulations within P10 syndrome who may be more likely to benefit, neurocognitively speaking at least, from mTOR blockers or mTOR inhibitors than those who may not be. So to answer your question, I think should we explore different medications, not just everolimus? Should we look at sirolimus? Number one. Number two, should we explore different subgroups that may be more likely to respond to this class of medications, neurocognitively speaking at least? And I guess number three, anecdotally from the trial, we heard from some family members saying, these set of symptoms got better that we weren't really, we were making a note of, but it was not part of our primary or secondary outcome measures. So certain growths or skin lesions or whatnot, we tracked this data a little bit, and so it might be interesting to actually look at the data we collected and see, well, apart from these kind of neurocognitive measures, what about these systemic or what about these non-neurocognitive data points that we collected? Is there any kind of interesting signal there? That I think that remains to be explored, and certainly we should look at that data next as well.
I've two quick questions. One is, if you look at those that responded versus not, was there any trend for the responders to be younger versus older? I realize it's a relatively small number of.
Right,
of
right.
pa-
We
patients.
didn't, that's a great question. We didn't look at that yet. That's one of those things that we are planning to do in terms of age, in terms of male, female, in terms of genotype, in terms of autism diagnosis, in terms of seizures. All of those are really, really excellent things to look at. We haven't done it yet, but we plan to do so.
Okay. The second question is a bit technical, I guess, but did you correct for multiple comparisons? You know, if you ask 20 questions of any population, one of them by chance will end up being marginally significant, and most of the ones that you showed either weren't significant at all based on p-value or were fairly weak. And if you did any correction for multiple comparisons,
Right.
it probably wouldn't be. So
Right. We had a discussion. The short answer, we did not correct for multiple comparisons, but we had a discussion with our statistician about it. And given the small numbers and the fact that we were casting a wide net, we felt that it was important to highlight. If there was a signal, it was important to highlight that signal and not necessarily dilute that. With perhaps larger numbers, I think that might be a more important consideration. But in this data analysis, we did not.
Thank you so much.
Great, thank you.